Now this session will be on management of percutaneous tubes, specifically gastrostomy tubes, biliary tubes, and nephrostomy tubes. Now the reason we include this in the curriculum is the fact that WOC nurses are frequently consulted, either because the tube is leaking and staff wants you to pouch around the tube, or the tube is leaking and the patient has massive skin breakdown. They want to know how to manage the skin breakdown. Or the patient has hypertrophic granulation tissue and they want to know how to manage that. So we're going to talk briefly about the most common types of tubes, what's out there, what are the differences. We're going to talk about routine management and how to prevent a lot of these complications. And then we're going to talk about how do you manage a leaking tube, peritubular skin breakdown, and hypertrophic granulation tissue. So first of all, let's look at our goals. If you can rewrite your routine policies and procedures for management of these tubes, and you can make sure that all of these things are followed, you can probably prevent most, if not all, of the problems that we encounter related to percutaneous tubes. So first of all, you want to make sure the staff is stabilizing the tube so that the tube is not moving in and out or back and forth. If you can stabilize the tube during the healing process, you'll get a sleeve of granulation tissue forming around that tube to hold it in position. If that does not happen, if the tube is not stabilized, you will get a lot of back and forth and in and out migration. You'll end up with tract erosion, massive skin breakdown, all kinds of problems. So tube stabilization is probably what we're going to spend most of the time talking about. Of course, we want to prevent dislodgement, and we will talk about that, and we'll talk very briefly about maintaining patency. Now you notice the postscript on this slide. A lot of times you are called to pouch around a leaking tube. You never want to pouch around a leaking tube until you're sure that the tube is in position. Now with gastrostomy tubes, that's not hard because they're pouring gastric contents. You can be pretty confident that you know exactly where that tube is. With biliary tubes, with nephrostomy tubes, you want to make sure the tube has not slipped out of position, because most of the time, if the tube is in position, it doesn't leak. So if you're having a lot of leakage around a biliary tube and nephrostomy tube, most of the time you want special procedures, interventional radiology, whoever put that tube in, to double check that patient, to verify that the tube is in position before you start pouching. Okay, so we're going to spend most of our time talking about gastrostomy tubes, and of course you know why gastrostomy tubes are placed, either to provide long-term decompression or long-term feeding. Now in terms of the types, I wanted to go over the types of tubes that are commonly used. They basically fall into three categories: either your PEG tubes, your balloon tip tubes, or your skin level devices. So when you look at this slide, and on top you see an illustration of a PEG tube. And PEG stands for percutaneous endoscopic gastrostomy tube placement. Probably most of you are very familiar with how PEG tubes are placed, but just in case, I'm going to go through it very briefly. It takes a two-person team, and an endoscopist, and then a surgical assistant. The endoscopist does local anesthesia, passes the scope down into the stomach, inspects the gastric wall, identifies a good site for G-tube placement. The endoscopist then uses the light on the scope to illuminate that aspect of the gastric wall. And they usually have the lights down so that that's very clear. The surgical assistant then makes a little incision, typically a cruciate incision, into the abdominal wall after local anesthesia, and then passes in a heavy steel trocar. Through that steel trocar, the surgical assistant either passes a heavy surgical thread or a wire. So now you have access into the stomach through this steel trocar, and now you have a thread or a wire pass through the trocar. The The endoscopist uses the snare on the scope, grabs the wire or the thread, and then pulls it out. So now you have this very long wire or thread, starts on the outside of the abdominal wall, goes up the esophagus and out the mouth. Then you can figure out what they do next. They're going to attach the PEG tube to the wire or to the thread. So now it's hanging out your mouth, and this tube is now attached. Then they start pulling the thread or the wire, and the tube comes down until this bumper catches at the gastric wall internally. On the outside, this is what you have. You see there is no inflation port because there's no balloon. But what you have is a tube. You can cut the tube off. You can attach an adapter to allow you to feed. Now your PEG tube is going to give you very simple alternative to surgical gastrostomy tube placement, and that's why it's so widely used. You can do it literally in 10 to 15 minutes at the bedside without major anesthesia. But of course this tube is going to clog over time, so typically PEG tubes are good for a matter of months, and then we'll have to remove the PEG tube and place a balloon tip tube. Now one thing I wanted to point out about PEG tubes, most of the time this internal bumper that stabilizes it at the gastric wall, most of the time it's soft, so that you can literally pull it out through the abdominal wall. They have deliberately modified the design of the PEG tube to make it possible to literally remove the tube simply by pulling it out. And most of the time when you look at the writing on the PEG tube, you'll see an indication that this tube can safely be removed by pulling it through the abdomen. It'll say something like may remove externally or traction removable. So PEG tubes widely used for initial placement, especially in your more critically ill patients where they're trying to minimize the impact physiologically. So a lot of PEG tubes out there. And the giveaway that you're dealing with a PEG tube is there's no inflation port. Now when you take out a PEG tube and you replace it, you're going to replace it with a balloon tip tube. And of course we know the advantage to balloon tip tubes is that they're pretty easy to put in. Then you inflate the balloon, and the balloon of course keeps the tube in position. And then when you're ready to remove the balloon tip tube, you simply deflate, and then it's very easy to pull the tube out. I'm not going to pull it out because there's something else I want to show you with this little baby. But if I did completely deflate the balloon, it would be very easy to pull this out. The third type of device is a skin level device. A skin level device is designed for long-term management, especially in the pediatric and the older demented adult populations. Once the once a gastrostomy has been established, there's a special little measuring device so you can pull out the existing tube once it's well healed. You can pass in a little measuring device to determine the distance from the gastric wall to the abdominal wall. And that tells you how long the shaft on this device should be. So this one is a 3-centimeter shaft. So to put this little device in, you would remove the balloon tip device or the PEG currently in position, lubricate this, slide this down into the stomach, then you would inflate, and so you see what you end up with. The device is stabilized at the gastric level with the balloon and then sits snugly at the abdominal surface. You can open it and attach an adapter to do feedings or to give meds. Once you flush it, then you just close it back up. The advantage in dealing with children and demented adults is there's nothing to pull on. It's very hard to take this out, to remove this accidentally. So 3 major types: peg tubes, balloon tip tubes, and skin level devices. As we have already said, if you're thinking about changing out a tube, you have to know how that tube is stabilized internally before you go to remove it. If it's a balloon tip tube, no problem. You just take a syringe. But if it's a peg tip tube, you have to know, is it a soft internal bumper and is it safe to pull it out through the abdominal wall? If it's a rigid device, or if you are unsure and you're asked to change out the tube, you would decline to do so, and you would send the patient to special procedures or GI clinic or wherever with a replacement tube that was balloon tip. And then after that, it's no problem to change it out. Now we're going to talk very briefly about biliary and nephrostomy tubes. It's much less common that we're consulted for management of these tubes because they're much less problematic. But occasionally you will have questions about this on the certification exam, so I want to go over some of the basics. So if you look at the top 2 slides, this shows the biliary tree. And of course you remember that you have the hepatic duct and the pancreatic duct, then the common bile duct that empties into the duodenum. Now this just shows you that biliary tubes, like T-tubes, are commonly placed right here in the bile duct, okay, before it becomes the common bile duct. However, you should realize that these tubes can migrate somewhat, and so you might start out with the tube being placed right here in the biliary tree, but that tube could migrate into the duodenum. That's important because when we talk about how to irrigate, if you irrigate, we'll emphasize do not aspirate. And the reason you would not want to aspirate is, what if the tube had migrated into the duodenum? And what if the tube had multiple little drainage ports up the side? If you aspirated, you could literally be pulling intestinal contents into the biliary tree, which would of course cause a massive infection. So you could have a tube into the biliary tree. And of course, nephrostomy tubes, you know very well, you have a tube that goes directly into the renal pelvis and decompresses the kidney. So both biliary tubes, nephrostomy tubes are placed simply to decompress and provide active drainage either of the biliary tree or of the renal pelvis. What about irrigation? Tubes can always get clogged and obstructed. So should we be routinely irrigating biliary and nephrostomy tubes? And most clinicians say no, no routine irrigation, because it's risky. You break the system, you attach a syringe, you instill fluid. If there's any bacterial invasion, then you're sending bacteria directly into the renal pelvis, directly into the biliary tree. So in general, if you have a nephrostomy tube that is draining well, a biliary tube that is draining well, you would not irrigate. Nurses never initiate irrigation without a specific order. Having said that, occasionally, in patients who have long-standing nephrostomy tubes, long-standing biliary tubes because of stenosis from a tumor, stenosis from scar tissue, stenosis from radiation therapy, occasionally you will have a physician order to irrigate that biliary tube, that nephrostomy tube. And if that happens, there are specific guidelines, and here they are. First of all, only with the physician's order, as we've said. Obviously, strict sterile technique. Also, low volume, because look where you're putting this, into the biliary tree, into the renal pelvis. The renal pelvis is low volume, the biliary tree is very low volume. If you put too much in, you're going to cause major distension and pain. So typically 2-3 cc's, no more than 5. And finally, do not aspirate for 2 different reasons. Aspiration creates negative pressure in the renal pelvis, which is painful. So no need to aspirate, you would not aspirate. We already talked about the fact that a biliary tube can migrate through the biliary tree into the bowel. And many of those tubes have multiple drainage ports. I was looking to see if I had one to show you. I do, if I can get it undone. So I don't know if you can see this or not. A lot of these tubes are secured by a little pigtail device, but this tube has multiple drainage ports up the side of the tube. So if the tip of the tube migrated out of the biliary tree and into the duodenum, then if you aspirate, you're pulling intestinal fluid back up the tube where it's going to drain out of these little drainage ports and into the biliary tree. So rule of thumb for safety, if you are asked to irrigate a biliary tube or nephrostomy tube, rules are physician's order, strict sterile technique, very low volume, no aspiration. Okay, now we're going to turn back and focus on gastrostomy tubes, and we're going to talk about routine management. Then we're going to talk about prevention and management of complications. Most of the time you're consulted for complications. So when you're looking at daily site care, you want to teach your staff to just clean with soap and water. You want to teach them do not continue to use peroxide once all bleeding has stopped. You don't have any issues with crusting. You don't want to use peroxide past that point, because there's some evidence that repetitive use of peroxide can actually contribute to hypertrophic granulation tissue. So you don't want to do that. You want to teach them clean with soap and water, keep the site dry. Now let me show you my little baby here. Inflate my tube. One of the things you want to teach the staff to do at the time of site care is to rotate the tube 360 degrees. So you see I'm not putting any traction on it, I'm not pulling it, I'm simply rotating it. And in rotating it, I'm breaking up any adhesions that are forming, any scar tissue that would tend to lock that tube or that balloon into place. My analogy when I'm talking to patients, almost everyone has had a piercing or knows someone who has. So I remind them that if you get your ear pierced or your belly button pierced, they'll put in a stud or they'll put in a loop, and they will tell you to rotate the stud, move that loop back and forth, and the reason is to break up any scar tissue and to prevent essentially entrapment of the tube and balloon. I remember having a patient some years back before I knew all this, and his wife was telling me that every time they had to change out the G-tube, it was awful for him because the nurses would try to remove it. He was in home health. The nurses would try to remove it. They would be unable to remove it. They would send him back to the physician. The physician would, as she said, rip it out and he would bleed massively. And she said it happened every time they changed the tube, so you can see what was happening. No one knew the importance of 360 degree rotation, and so he kept forming scar tissue that was wrapped around the tube and the balloon and locking it into position. Very simple maneuver, 360 degree rotation daily until the site is well healed, which is usually about 6 to 8 weeks. Thirdly, most of your balloon tip tubes will be these silicone type tubes, silicone balloons, and these balloons leak down steadily. So if you inflate it with 20 cc's, which is the recommended volume, on say April 1st, and it's now April 10th, you're thinking there's still 20 cc's in the balloon, but there aren't. There may be 10, there may be less. And as the balloon continues to leak down, it becomes progressively easier for the catheter to be dislodged. The recommendation is to routinely deflate and reinflate the balloon. So some agencies have Tube Tuesdays. If I have Tube Tuesday in my agency, then on Tuesday, for any of my patients who have a balloon tip tube, you're going to take your syringe, deflate the balloon, then look at the recommended volume, reinflate with the recommended volume. So you know that your balloon is never significantly deflated. So weekly deflation, reinflation. And then finally, what do we keep saying? You've got to stabilize the tube until the tract is well healed. Now, I want to just show you something that you can turn around and show your staff. They need to understand the importance and the concept of two-point stabilization. And that's actually why I have this little doll, because I used her to give an in-service in a long-term care facility where it was clear they didn't understand that, because every time I was consulted, I would go in and the disc would be way out here. So what I was showing them is that this balloon provides stabilization at the gastric wall. But that does not keep the tube from moving back and forth. It just keeps it from falling out. So if my disc is not in position, the tube is doing this, back and forth, in and out, back and forth, in and out, every time that patient moves. But if I have the balloon inflated correctly, and then I use the skin level silicone disc, and the silicone disc is sitting right at skin level, it doesn't matter what this patient does. That tube is not moving. It's not moving in and out. It's not moving back and forth. If you hold the tube stable, you get that sleeve of granulation tissue that forms around the tube. You have a well-healed tract. You have minimal risk of leakage and skin breakdown. So you want your staff to understand the importance of stabilizing the tube. Now, what are your options? Well, we've just talked about the silicone disc. So the silicone disc should sit at skin level. The balloon should sit at the gastric wall. Silicone disc should sit at skin level so that the tube is not moving. What if you have a tube and there is no silicone disc? Let me back up. I know you hate it when I do that, and I'm sorry. But what if I have a tube with a silicone disc and the nurse wants to know, can she put gauze underneath? Because maybe there's a little bit of leakage. Yes, she can. Is it necessary? Only if there's leakage. There's nothing magic about gauze, although that's a widely held belief that somehow gauze magically makes things better. So if you wanted to put gauze underneath this, you would tell her, stabilize the tube at the abdominal wall, move your disc back, do side care, place your gauze, and then re-advance the silicone disc. As long as your disc is there, you're fine. What if there was minor breakdown and they wanted to put a hydrocolloid between the skin and the disc? Same thing. So can you put a dressing underneath the disc? Yes, but then replace the disc so that the tube is stabilized in position. In some cases, you might come in and you might have a tube without a disc. Maybe somebody cut the disc away. Maybe it's a tube that doesn't come with a disc. So I'm going to show you a very simple thing you can do. You can put down a hydrocolloid wafer. You can take a regular baby nipple and just split it up the side. Put the baby nipple around the tube, and then just tape the baby nipple to the hydrocolloid. So we've done this. We started out doing this with pediatric patients because it was very easy to teach the parents how to remove the baby nipple, clean around the tube, put the baby nipple back, and tape it back into position. Also, it involves inexpensive, easily obtained supplies. And then once I get that done, what I'm going to do is I'm going to take my last strip of tape and I'm going to tape right around the baby nipple to the tube. And then the tube is going nowhere. So very simple, easy to teach, easy to find the supplies. And of course, there are also commercial devices that you can use. So either your silicone disc, your commercial devices, or a hydrocolloid wafer and a baby nipple are great ways to stabilize the tube. The limiting factor for all three of those is that if your tube is leaking, they don't work. So if I have major leakage around this tube, obviously I'm going to be in a constant mess. I'm either going to constantly be changing gauze, which is going to hold fluid against the skin and cause skin breakdown. So no good way to manage significant leakage with the silicone disc, or not by itself. What about this? All the drainage would be trapped under the baby nipple. Not a good idea at all. And same thing with the commercial device. So what I want you to realize is these approaches to tube stabilization are for prevention. This is routine care. This is how you keep problems from happening in the first place. Once you have a major problem, these approaches won't work. You have to move on to another approach that we're going to talk about. Okay, so let's talk about a leaking G-tube. And of course, you know what the problem is. Most of the time you have tract erosion. So when you go to see the patient, the hole around the tube is much larger than the tube itself. Typically you have significant skin breakdown, sometimes much worse than this. And the patient's leaking large volumes of formula and gastric fluid onto the abdominal surface, causing major skin breakdown. I could dress around that, but I would have to change the dressing constantly. So could I put down something like zinc oxide in a foam dressing? Yes, but that foam dressing is not going to handle hundreds of cc's of drainage. So that's a good option if you have minor leakage, not a very good option if you have major leakage. So if you look at the next page, in your hard copy module or on your electronic document, we're going to talk about a procedure called pouching, how you pouch around a leaking G-tube. Our goals: we want to stabilize the tube. We want to prevent further tract erosion. We want to hold it in position so that we can start to form that sleeve of granulation tissue that holds it in position. So I've got to go back to what we didn't do and stabilize the tube so that we can start the healing process. But at the same time, I've got to have a way to collect the drainage and protect the skin. And most of the time, we still need to feed through that tube. So I've been consulted on cases where the nurses said, we tried to get the surgeon to discontinue the tube because it's a mess. But he doesn't want to discontinue the tube because he said the patient needs the feeding. And if he removes this tube, he'll just have to turn around and put in another one. And you know what? The surgeon is right. So what we have to do is stabilize the tube so healing occurs, collect the drainage, protect the skin, and maintain access for feeding. Now I want to point out one advantage to pouching. Not only does it get the drainage off the skin and into the pouch, but it allows you to quantify the amount of drainage, which in turn allows you to determine whether or not you're making progress in getting that opening in the gastric wall to heal. So let's say that week 1, the first week you pouch, you're feeding, say, 2 liters a day. Let's say this is an adult, you're feeding 2 liters a day. And during week 1, you get 1,000 cc's out a day into the pouch. Okay, the patient's leaking a significant amount, but they're also still retaining half of the feeding. What if week 2, they're leaking 500 cc's a day? Okay, well now we know we're making great progress because we have cut the volume of fluid in half. So many advantages to pouching. Okay, so let's talk about how to do it. And the first thing I have to tell you is you will practice this in class. It's one of those things that's very hard to learn from a slide presentation or even a video. But I am going to walk through the major steps with you. I'm going to try to show you, but I can tell you you're going to have to do it yourself. So the first thing you want to do is get a 2-piece fecal pouching system. You want to size the opening in the wafer to be larger than the opening in the skin. So if the opening around the G-tube is 3/4 of an inch, then the opening in the wafer has to be at least 7/8 inch to clear that. Now this is the confusing part. You're going to put 2 loops of suture through the flange of that wafer. And you're going to use those 2 loops of suture to tie around the tube and stabilize the tube. So I'm going to try to show you this. What we typically use is 2/0 silk on a cutting needle. So I happen to be right-handed. If you're right-handed, the sharp end of your needle needs to face your left shoulder. If you're left-handed, you reverse it, and the sharp end of the needle faces your right shoulder. I want you to see that I'm placing my needle holder right at the apex of the curve. And I'm going and clamp it down because I want to have good wrist action. I'm going to take my wafer, I'm going to push the needle through from the inside of the flange out, then I'm going to reposition. I'm going to come back through right at the same point in the flange so that I have a loop. Now, I want you to notice 2 things. The suture goes through the flange, not through the wafer. It goes through the flange itself. Secondly, I want you to notice that my loop faces the tube, and that's important. So I always start on the inside of the flange and go out, and then the outside of the flange and come in. I'm going to pull it down about halfway. I'm going to cut this off. I think. And then I'm going to use the other half to do a loop on the opposite side. So again, try to watch what I'm doing. I'm starting on the inside of the flange and coming out, and then I'm coming from outside in. Now you've probably already figured out why we prefer to put our loops of thread in before we put the wafer on the patient. Because I'm working pretty close to the skin. If this was already on the patient, I'd have to be ultra careful to make sure I did not catch the patient's skin when I was putting in the loops. So we prefer to do that before we apply the wafer. So we get our wafer ready. When it's ready, I have an opening that's larger than the opening in the skin, and I have 2 loops of thread facing the center. Now I'm going to clean the skin, I'm going to treat any damaged skin areas, and I'm going to put this down around my tube. Now let me show you how we tie it around the tube. You can see on the slide. And now I'm going to have to put loops of thread into my other demo, so just bear with me a minute. This one's already stuck down to my pretend patient. That's okay, it won't hurt to go through it again. So I start on the inside of the flange and I come out, and then I come outside in to form my first loop. And you can do this when it's already on the patient. I've had to do it when it was already on the patient, but I much prefer to do it when it is not on the patient. Okay, so now I've got my first loop. I'm going to do exactly what we talked about. Now I cut it off, and I'm making another loop on the opposite side. And you start on the inside of the flange and you come out, and then you reposition and you come outside in. Now I have my 2 loops, and I'm going to show you how we tie it. one of the hard things is going to be trying to show you this because I don't have anybody to hold my patient. But this is when I would go and I would get the staff nurse, and I would say to the staff nurse, I need you to help me for 2 minutes while I get this tied. So I'm going to even up my threads, and I'm going to try to show you this. I don't know if I can demo this or not, but I'm going to try. Okay. So I'm going to take my threads in front of the tube and crisscross them. I would never flip my patient like that, just so you know. And then I'm going to come in back of the tube and I'm going to crisscross. And I'm going to come in front of the tube and crisscross. So I'm going to do that several times. And then I'm going to do a straight tie. Now if you have any fancy knots you want to do, that's fine. But if you don't have fancy knots, you can just do a straight tie. Typically about 3 times, making sure that you do not tie so tightly that you occlude the tube. So in just a minute, I'm going to be able to show you what we've done here, I hope. Okay, so now my tube is stabilized. And that is going to meet goal number 1, so that the tube is held in position, is not allowed to move in and out or back and forth, so that I form a sleeve of granulation tissue. Now, if I did this, even if I didn't pouch, I would have done 2 things. I would have treated and protected my peritubular skin. I would have stabilized the tube, so I could tuck an alginate or an aquacell rope down into the tract to kind of wick the drainage out, and I could split ABDs or whatever, or very highly absorbent diaper squares, like diaper squares with superabsorbent polymers. I could cut them around to absorb the drainage. But that's not as effective as if I pouch. So let me show you how we get ready to pouch. We take our pouch for our 2-piece system. You're going to take tape and you're going to cover the front of the pouch right over the flange. This just reinforces the pouch material so that it doesn't split when we start cutting. Now I'm literally going to cut an X. And I can cut a very narrow X if I'm just going to bring the tube through itself. But I'm cutting a little bit wider X because I'm going to bring a baby nipple through. I want you to see how you can use a plain old baby nipple to support your tube and prevent leakage. So I push the baby nipple through from the inside out, and then I keep pushing until it's sitting up on top of the pouch just like it would sit on a bottle cap. Now I have to tape around the base of the baby nipple very well. I've got to occlude the opening in the pouch to the extent possible. And I'm going to show you in just a minute that you do not tape up and onto the nipple. You tape around the base so that you get a nice secure seal at the base and so that you minimize the opening in the pouch. So I actually kind of lift my baby nipple up and tape under it. And when I've got it all taped, I really should not see the hole in my pouch. It should be very secure, and my baby nipple should sit on top. Then I'm going to take my scissors. You could cut a hole, but usually we just cut a deep slit. And I want it deep enough that it does this. And then I'm going to push my hemostats through the front of the baby nipple. I'm going to collapse the drainage end of my tube, and of course I would not be flipping my patient around like this. And now I'm going to pull it through. I'm stabilizing the baby nipple because I don't want too much traction. I feed it all the way through. Then I snap my pouch onto my wafer. Now I'm going to tape my baby nipple to the tube, and now I have a very secure system where the drainage will go into the pouch. I'll contain the drainage, I've got the skin protected, and I still have access for feeding, plus I've stabilized the tube to start the healing process. So that's how you pouch around a leaking G-tube, and I have to tell you the one added advantage to that is that you impress the heck out of people when you do that, because they're like, wow, how did you know to do that? And because it makes such a difference. It starts turning things around, the skin starts healing, the hole in the stomach begins to close, the volume of leakage diminishes, and typically within a couple of weeks, the area is healed. You will get to practice that. Okay, a couple of other issues I wanted to mention briefly. If you talk about management of hypertrophic granulation tissue in a wound, you automatically think of silver nitrate, which is very appropriate. You can use silver nitrate for hypertrophic granulation tissue around a tube. The problem is that many of these patients are outpatient, and it requires repetitive treatment, and most of the time we're not comfortable teaching the family or the patient how to apply silver nitrate to themselves. Secondly, it's very close to intact skin, and for many patients it's very sensitive. So it's not that silver nitrate is wrong. Silver nitrate is an option, and typically you would follow the silver nitrate treatment with a foam dressing, because we know foam dressings keep the area drier and help to flatten out hypertrophic tissue. But there's another option, and that is triamcinolone spray or solution, also known as Kenalog. It's a mid-potency steroid, and it rapidly reduces the level of hypertrophic granulation tissue. We had a little boy, and he had been fed by gastrostomy tube his whole life. He was 5 years old. They were ready to close his gastrostomy because he was now able to eat, which is really happy. But he had such massive hypertrophic granulation tissue that it was impossible to determine whether it was just hypertrophic tissue or whether the gastric wall had actually turned back on itself to form a permanent gastrostomy. So the surgeon sent him to us. We taught the mom to apply Kenalog spray followed by a foam dressing every day, brought him back in 2 weeks. In 2 weeks it was crystal clear that he did indeed have a permanent gastrostomy, and he needed to go to surgery to have his gastrostomy closed. It wasn't going to be enough to just pull the tube. So that's a very effective option. And of course, tube stabilization, because that's a contributing factor to that hypertrophic granulation tissue formation. What if the tube is clogged? Well, of course, everybody has their favorite solutions: Sprite, Coke, cranberry juice. Interestingly, the Society for Parenteral and Enteral Nutrition Nurses did a study, and they found that for most patients, Coke, Sprite, no more effective than warm tap water. We know what causes it is clotted formula in the tube is what causes the tube to obstruct. So the most effective approach is to use an enzymatic agent that will break down that protein clot. Add to it sodium bicarbonate to reverse that very acidic pH, because when you eliminate the acidity, then pepsin stops working and clot formation stops. So you can mix pancreolipase enzymes, which you can get from pharmacy, with sodium bicarbonate, plain old baking soda, and warm water, form a slurry, instill like 5 cc's into the tube right around the clot, clamp it for 30 minutes to an hour, come back and try to irrigate. And most of the time that will open it up. They also make little kits for use in home care that have all of the ingredients. So just wanted you to know that. And then the last thing we're going to mention is gastrostomy tube replacement. In most states, nurses can replace gastrostomy tubes when you have a well-established tract. There's no reason we should not be able to. It's much simpler than replacing a Foley catheter. So here are the guidelines. First of all, you want to do your thorough assessment. You should have a well-healed tract. If you're going to deliberately remove a tube, you should know that the tract is well-healed and that you're going to be able to get a replacement tube in. And the tract will be well-healed after about 6 to 8 weeks. Should the tube come out at an earlier point, if you're on site, you should take whatever tube you can find, sterile tube, clean tube you can find, see if you can slide it in before the gastric wall closes. The issue is you would never feed through that tube until you had verified placement with an x-ray. So my point is this. If you have early dislodgement, is it appropriate to attempt replacement? Yes, absolutely. Don't force it and don't feed through it until you verify placement. But if you're planning a routine replacement, you're going to wait till the tract is well healed, which is usually 6 to 8 weeks. Then you're going to see, well, how is this tube stabilized internally? Is it a balloon tip tube? Okay, fine. All you have to do is deflate the balloon and the tube will come out. If it's a PEG tube, you have to make sure it's traction removable. So you have to see, do you have markings on your PEG tube? Are there notations in the patient's record? If you do not know how that tube is stabilized internally, you're going to send the patient to special procedures or GI lab with a balloon tip tube, but you're not going to pull it out at the bedside. So first of all, do your assessment, then get a new tube. It should be a balloon tip tube. Then you remove the old tube. You either deflate the balloon or you put traction on the abdominal wall and you pull out that traction removable PEG tube. You will get spatter, so you should have full personal protective equipment, and you should warn the patient that it's going to feel like a lot of tugging. It shouldn't be painful, but they will feel pressure. So remove the old tube, measure it against the new tube, lubricate the new tube and put it in, inflate the balloon, and then verify placement. So wait till you have gastric contents flowing back through the tube before you use it. In a lot of centers, they also do a pH check to verify that it is indeed gastric fluid. I think everybody knows this, but I will mention it, that we never use air inflation to check placement of a G-tube anymore, because the fact that I can hear the air does not tell me that that tube's in the stomach. It just tells me it's somewhere in here and I can hear the air going in. Okay, so what do we want you to know? We want you to know guidelines for irrigation of a nephrostomy tube or a biliary tube. If there is an order for that, you should know what to do it safely. You should know the guidelines for routine G-tube management to keep that patient from getting into problems. You should know clean daily, rotate daily, re-inflate weekly, and stabilize, stabilize, stabilize. You should know how to use those skin level silicone discs and what to do if one is not available. And then once you have the class, we want you to be able to pouch around a leaking tube. Okay? Thanks a lot.